Ahoy, friends, and welcome back to the Death with Dignity podcast. My name is Andrew Flack, and I'll be your host. As a licensed clinical social worker with the University of California, San Diego, Monika Lingle has significant responsibilities supporting patients and their families as they navigate their way through the medical maze that comes with the cancer experience. Today, she joins us to share more details about her role and how the End of Life Option Act is so instrumental in her field. We thank you for listening, we thank you for your time, and we hope you enjoy the episode. Welcome, everybody. We are here today recording for the Death with Dignity podcast. We're here with Monika Lingle, who is an LCSW for Moores Cancer Center, located with UCSD, or University of California, San Diego. We're here today to talk a little bit about the social emotional piece connected with Death with Dignity, or Aid in Dying, as it's sometimes referred to. It is also called the End of Life Option Act, which was the bill that was passed in 2015 and signed into law. But Monika, thank you for joining us and making the trek here to Oceanside. Tell us a little bit about yourself and just your role and what you do and how you got involved in this field.
Okay, well, thank you so much for asking me to talk to you today. I love talking with people. That's part of why I'm a social worker, and I'm happy to talk about Aid in Dying, or the End of Life Option Act, with you. I've been a social worker since 1992 and have always worked in healthcare, in the medical setting. And when the Cancer Center when the law first passed and the Cancer Center, or UCSD, was involved, there was a social worker who was doing all of our meeting with all of our folks who are interested in Aid in Dying. And the way the oncology group ended up getting involved was that social worker was preparing to retire. And so came up with how are we going to meet this need? And as we looked at where most of the patients, where most of those patients' referrals were coming from, was from oncology patients. And so the social worker who'd been involved met with the social workers at Moores and asked if we thought it was something that we would be interested in. And we absolutely, all of us, were really supportive of taking this on as part of our work with our patients and families. And so and tell me if I'm answering your question.
No, this is great.
Okay.
Yeah, no, and we tell everyone who's listening and out there, we're all new to this whole experience. So we appreciate the conversation and the opportunity to talk. And yeah, feel free to go with the flow and just share maybe your role, obviously within Moores and such. And we obviously have a couple guiding questions as well. But yeah, this is great.
Okay.
And an LCSW, tell us what that stands for and what that gives you the ability to do, I suppose, or your role, how you support others in that role.
Okay. So LCSW stands for Licensed Clinical Social Worker. And so in California, that's the licensing to be a social worker. So we all have a graduate education and master's in social work. And then to become licensed, we need about a little more than 2 years of supervised practice. And then there's a licensing exam that back when I took the exam was an oral exam and a written exam. And having an LCSW allows a social worker to do private practice. It allows different, like I said, my background is in healthcare. A lot of hospitals or health centers don't require the license to work there, but it's pretty well expected if you have your MSW that you'll pursue licensing, and so there are some jobs that require a license, and Morris Cancer Center does require our social workers to be licensed.
Sure.
Um,
And MSW, is that like
at
Masters of
Masters in
Social
Social
Work?
Work.
Okay. And then the LCSW is kind of that extra step, which enables or gives you that extra, I guess, pedigree in a way.
Yeah,
Yeah.
yeah.
And then as a school teacher,
Mhm.
we have LCSWs at our school who work with students and support the community there. What drew you to the health field versus something like education or even a private practice?
So I attribute that going back to when I was in college. One of my sociology classes, um, it was actually sociology of mental illness. And in one of the classes, he talked about unresolved grief, not necessarily as a mental illness, but he talked about unresolved grief. And I found myself really moved by that. I'd experienced some losses as a senior in high school. I had during separate events, two different classmates die. And so I was really just struck by by the concept of unresolved grief and how much that related to my own experiences. And so I found myself becoming really interested in bereavement and grief. And this was back in 1986, and well, it's 88 maybe by then. And the AIDS epidemic was huge. And so I ended up being hired as a student educator about HIV and AIDS prevention. And then that sort of led into healthcare. And so then when I was going to graduate school and had to pick sort of an internship track, healthcare, the bereavement interest led me to working in a hospice setting. And then,
interesting.
Yeah. And so then as a bereavement counselor was my first internship. And then after that, my next internship was actually at Rady Children's in the ICU. And I fell in love with being in the hospital.
Sure.
In that setting. So I've, since that time, I've either been in an ICU ER setting or in a hospice setting. And I've felt like over time, working in the cancer center, having that experience of both inpatient acute care and outpatient hospice, more palliative care, end of life care. Oncology really encompasses both, or is the trajectory. And I feel like part of my skill set is I'm able to go from, I can tolerate the balance of pursuing treatment and the hope that people will get better. I can balance that hope with the knowledge that people don't always get better. And I can kind of, my goal is to stay with our patients wherever they are on that journey.
Sure.
Stay with them emotionally and be able to kind of tolerate that. I've heard it called like tolerate that tension of balancing those things.
Absolutely. I think that's one of, through my own experience, the hardest pieces is finding that realism and accepting where you might be going with the trajectory or the prognosis.
Mm-hmm.
And for myself, I've experienced a lot of different emotional states, denial. It seems like almost I guess the standard stages of grief, if you will.
Mm-hmm.
And eventually at least for me, I feel like I am at a point where I've accepted my prognosis and where I'm heading, which is why the topic with death with dignity has become so important in a sense. And just from hearing you talk a little bit, it sounds like you're the perfect person to be in that role. And with your experiences, you mentioned hospice and having that interest and desire to work with people in the bereavement setting.
Mm-hmm.
So that's huge for, I'm sure, your patients and such. And tell us a little bit about your work with patients, specifically with aid in dying. how you support them in the process, and maybe some of that emotional, I guess, roller coaster that others
Hmm.
may go through, what that might look like.
So, as I think you know, the Cancer Center, our teams are determined by, we call them disease teams. So each social worker, so that, for example, there's a breast team social worker, there's a, a lung team social worker, and I am the GI team social worker. So each social worker um, took on as part of our being part of our team is that if a patient has questions or wants to talk about aid in dying, um, it made sense that the social worker who was part of their care team would be the one to talk to them about that. That was kind of how that decision
Sure.
was made. Since I know those doctors, I know sort of hopefully know enough about how all of the different cancer diagnosis that our patients are experiencing. Um, so my role, if someone has questions or wants to talk about aid in dying, is to make contact with that person. And um, this probably won't surprise you. Every doctor has a little bit different comfort level in talking about it. So some of our doctors are great at explaining the whole process. They tell their patients about it. They don't necessarily have a lot of patients may not have a lot of questions for me about the logistics of the process. Some people have, they kind of know about it, but they don't know very much about it, and I kind of start from the beginning and explain the process to them. I've thought a lot about um, your. You had prepared me. One of the questions is what are people's emotional responses to it, and my experience really consistently has been, and other social workers have shared this with me as well. A lot of times, by the time someone has expressed an interest in aid in dying to their doctor, they've kind of already decided that it's something they want to pursue.
Sure.
Um, and so I haven't seen people have a lot of ups and downs. And what I generally hear from people is a sense of relief. Um, I actually just talked to a woman today who said she felt like a huge weight had been lifted in talking to her doctor about it and then talking with me about it and being reassured, yes, we can have that. This is an option for you and we can make that happen. Um, so a lot of people have already kind of gone through the emotional roller coaster of, is this something that I'm interested in? Um, and so what I have found more often is families, their partners or their family member wants to sort of process that a little bit more. Most of the folks that I've talked to are really, once they're talking to me about it, they've made that decision.
Yeah.
Not necessarily that they're going to take the medication, but that they want to have that option.
Sure. That makes sense. And tell us about how that experience is with the family, because from my experience as well, I had a conversation with my doctor, my oncologist, Dr. Miller, and he was able to coordinate bringing my parents in to talk with him as well. And that was very, very helpful for them and my family as a whole. So, how do you make yourself available, I suppose, to those other family members? Is that a role that you, I'm sure, embrace and help advocate or support them in any ways?
Absolutely, as much or as little as folks want. It's sort of evolved with COVID, and haven't been seeing it's. We're opening up a little bit more now, but in the past, I've met with patients and their families in the clinic, or made appointments with them outside of their clinic visit to sit and talk. Um, in the last year and a half, most of my conversations with folks have been over the phone, which can actually still feel pretty intimate.
Sure.
So I think for family members, there's more of that sort of acceptance um, continuum that they see the person that they love suffering or dealing with Sometimes it's extraordinary pain. Sometimes it's extraordinary fear of pain or of losing their sense of self or dignity, and and no one wants the person they love to die, ever. And I think when one of our doctors has described it as taking the aid in dying medications isn't about making a choice to die. It's about making a choice about how you're going to die. And so, as sad as many family members are, husbands or wives are about it, if they get to that, if they get to the place of feeling like, I know my person's not choosing to leave me, it's not about that. It's about how can I best support them at their end of life. And many folks they get to a point where they're never happy that, folks are never, acceptance is such a weird word. It doesn't mean you're happy about it or glad about it, but
Sure.
A lot of people end up feeling that it's one of their final loving things they can do for their person is to support them at the very end of their life.
Absolutely. I think in a lot of cases, the greatest gift that we can give to somebody in that situation is to end that suffering and provide that way out in a dignified and humane manner. That's at least what I'm starting to feel and learn more as we investigate this whole idea. So, as you mentioned, patients generally seem like they are more at that level of acceptance and almost wanting to have that option. And their families might be more at a stage of wanting to know more about it. And I thought you did a good job explaining what that process might look like for them. I wonder as well, have you worked with families or people who have the opposite, I guess, viewpoint of aid in dying and disagree with the idea of it or the philosophy of it? And with that, I wonder too what your thoughts are as to why that might be or why this whole subject is kind of a taboo subject in, I think, the medical community and society in general.
I've definitely met, whether it's coworkers, or and our some patients' families who are not supportive of the idea, and some of what that can look like is a husband or wife who controls the conversations. For example, if I call, and this has happened to my social work colleagues as well, you may reach out and call, and and sometimes folks don't feel well, so they're not the one to answer the phone. And husband or wife will tell you straight up, I'm not happy about this. I'm not happy that they're asking about this. And they'll say, yes, 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 I'm going to tell them that you called.
And they
And then
happen to forget.
you never hear back. And so
Mhm.
then, that can sometimes be a little worrisome. Are they getting the message that they asked for this? I want to make sure they feel heard and that they have the information. But I have seen that evolve over time with a husband who was pretty protective of any of us having this conversation with his wife. And over time that evolved. And I think one of the things we feel really strongly about is we want to make sure that whether or not someone is planning to or wants to use the end of life medications, that their symptoms are really well managed. I have a really hard time with our patients being uncomfortable or in pain. I think probably because I've worked in hospice, I know how well hospice does at mitigating that. And so I'm a huge proponent of hospice care. And I try to really reassure our families that, first of all, a lot of folks don't know anything about hospice care. And so I try to give them education about what hospice can provide. And when we do have a patient who's ready to stop their cancer-directed treatment and is interested in aid in dying, one of the things that we um, almost insist upon is that they are followed by hospice at home when they plan to take the medications. And there's some sort of really nitty-gritty details about why, but part of it is so that before they ever take the medication, that their symptoms are well managed. Um, and for a lot of folks, and I try to reassure families this, lots of people will go through the whole process of obtaining the prescription and then never use it. It's just that sense of relief and safety, knowing that it's there in the event that their quality of life is so poor or their pain is so poorly managed that they know they have that as an option. I think for a lot of folks, when hospice is involved, they don't get to that point. They are really comfortable. But and so I think for some spouses and family members, that is reassuring that we're not trying to push aid in dying. We're just giving folks an extra layer of support, an extra option.
Absolutely. And from your experience working in hospice centers or with them, closely with them, how are they involved in the process? And from my understanding, there are some hospice centers who might not be supportive of the idea of aid in dying. And I wondered, again, if you have experience there or if you have an idea as to why that they might have that philosophy.
I have had experiences with that. In San Diego, there are a few hospices that in what we would call fully participate in aid in dying, meaning that their physicians will act as attending physician and write the prescription. They will provide the consulting physician to confirm the diagnosis and prognosis. They'll do the whole process with the patient. That's what we consider fully participating, and they do that without additional charges for patients and without referring them to an outside private physician.
Okay, that's nice.
Yeah. There are hospices who say they support the process or are supportive. But they, if a patient asks about it, they'll refer them to a private physician who can charge upwards of $10,000 or $15,000 on top of then the cost of the medications. And in our thought process, that's not being supportive. Or not. It's not that they're not being supportive; they're not fully participating.
Sure.
Some hospices will are supportive in that they'll allow their staff to be present at the time the patient ingests the medications. Some hospices don't do that, and their staff won't do that. Sure. My sense of why it's I think there are a lot of different reasons, but I think for some people there is a misconception that physician aid in dying or medical aid in dying is suicide. That's not our perspective in our team that helps patients. And that goes back to, it's not about making a choice to die. It's making a choice about how you're going to die.
Sure.
And I would liken that to, we want people to have a choice about, are you at home? Are you in the hospital? Do you want, if your heart stops, do you want CPR? I mean, to me, those are choices that people can make about the end of their life, as is taking the aid in dying medication. But my value system and framework is that people have a right to privacy and autonomy. To me, it's very similar to whether you're pro-choice about reproductive freedom. I see it as being very similar, and so that's my own personally. That's why I'm supportive of it. But I think the taboo goes back to considering it suicide. Some people think it's playing God.
And to touch base on the suicide subject, mm-hmm. The law was passed and written so that, for example, on the death certificate, it wouldn't say something like died by suicide.
It does not. It should not say that. That's not
Right.
right.
Right. So from what I've read and kind of understand, that this is a big piece as to why I think there might be some controversy, is, as you
Mm-hmm.
mentioned, some people might consider it suicide. Do you think that is a component in the medical community itself as to why some others might not be supportive? Or maybe it goes back even for doctors and like the Hippocratic Oath or something like that, and promising to do no harm. Could that also be a factor, just from your own experience?
Absolutely. I think that's probably part of it.
Sure.
Um, and I think and we can have all kinds of philosophical conversations of what means doing harm.
Sure.
Chemotherapy, radiation, immunotherapy can make people really, really sick.
Absolutely.
So with the intention, again, and when you talk about bioethics and more, you have to look at what's the intention. And your intention when you're giving someone chemotherapy is not to make them really, really sick, but that's a side effect.
Certainly.
So,
And you could argue that by not providing this choice, let's say a patient is suffering at the end of their life, and if a doctor were not to agree to give this to a patient, are they doing harm to that patient when we know that inevitable outcome is death?
right.
So I think certainly there's a a side to every story, and each side
Absolutely.
of the coin and all that, and I can see why it is such a sensitive subject. And not only
Yeah.
that, but we're talking about really the most deep and profound experience that we have as a species, the end of life.
Right.
I mean, this is something we will all experience, but at the same time, even though it's something we do have in common with each other, it's still so very taboo, as we mentioned earlier,
Right.
to discuss it. When the bill, this is something I wanted to circle back to, when it was first introduced and first coming about in the medical community, we did a little recording earlier, and we know that this was years in the making, decades in the making, getting this bill around. When did you first hear about it, or hear rumblings about it, I guess, in California as a professional? And how did that develop over the years, just from your own personal perspective?
Gosh, it's hard to even think back about when I
Sure,
first started
yeah.
thinking about it.
And there were
I'm trying to think.
multiple attempts throughout even the 90s and early 2000s with legislation. And here in California, it seemed like the big tipping point was a woman named Brittany Maynard.
Mm-hmm.
She ended up moving to Oregon from California, her home state, so that she could take advantage of the death with dignity or aid in dying law there. And the year after that is when California really.
And I think Brittany and her husband really brought this into the mainstream consciousness with
Yes.
Cover People magazine. And
How was that experience for you at that time in California? And just were there rumblings at UCSD or discussions between you and other social workers?
I'm not sure that we really, I think we probably thought about it and hoped that that would be an option for our patients. I think my response to Brittany Maynard was how sad it was that she had to leave her home in order
Sure.
to get that care. Um, I think I've had been asked a couple of times to give talks to social work graduate students about death and dying. And one of the questions that would frequently come up is, what do you think about euthanasia? And I always say, well, it's illegal. We don't, and that's also something that people, I think, need to understand about aid in dying. This requires that a patient be fully aware that they're participating. We're not, it's not a decision for someone else to make for them or do to them. It's, and I think that is also part of the taboo about it is, are we taking advantage of, are we trying to
Maybe
off
people.
somebody
Right, right.
and that's not what it's about. And
Yeah,
that's,
and that's a huge point and piece to hold on to, is exactly that. This is the patient ultimately making that decision for themselves.
yes.
And I could see how people might, wonder what the process is like and what's behind it, and if exactly that, if it's something like the doctor or the family making that decision,
Hmm.
which is not the case.
Right. And there's quite a bit of safety net built into the law to make sure that it's the patient's decision and not anyone else's, and that they're not feeling coerced.
Sure, absolutely. It is. It's a process, and I think it's a good thing that there are those safeguards, as you mentioned. And then as we kind of move forward with Aiden dying and this concept, do you feel from when it was passed in 2015 to now, and hopefully moving forward, do you feel there's been a change or less of a stigma, or maybe it's more accepting to talk about, whether it's in the medical community or just our society in general? Have you noticed a change, or do you think that's something that's still developing as more states and even legislation is passed throughout the country?
I think it's still developing, but I will say, in my experience at our healthcare center, um, initially there were only a couple of doctors who felt comfortable writing the prescription, um, and we've definitely seen more oncologists becoming comfortable and participating, meaning they'll either write the prescription or they'll act as a consulting physician and feeling much more comfortable um, helping their patients access that information. I think, initially we've come upon situations where it looks like a patient had asked their doctor about it and it nothing ever came of that. They
Sure.
weren't referred to us. It never went anywhere. I think we're seeing less of that. Um, I think physicians are, one of the things I hear that I always try to correct this misinformation is sometimes if a patient brings it up to someone in the hospital or someone on another team, they're told, oh, you know what, that takes forever. It's really complicated. There's so many steps involved. I don't think you don't want to fool with that.
Right.
And the reality is it's not that complicated. I mean, there are those safeguards, but it's a very straightforward process.
Absolutely. I would agree with that.
And I met with one family who'd been told, the patient had been told, this is really complicated. There's so many steps to it. It would be really hard for you to work through all that. And the patient was disappointed, saying, I really wanted to have this option available. And I was trying to reassure her that we can help you with the steps and it's not really that complicated. And her daughter pointed out, Mom, the other options that they're offering you are like this huge surgery, chemo, radiation, all these
Yeah.
different, like, that's complicated.
Sure.
This is
Yeah.
this is pretty straightforward. Like, let's get you
Absolutely.
connected with the hospice and help you with these, these visits to do this. So it's really, that's sort of a misinformation I think is changing slowly, that it's not a tremendously burdensome process for people to go through. And like I said, I'm seeing more physicians that are comfortable either talking with their patients about it or actually writing the prescription.
Absolutely. Well, that's good. And I think that there probably is still a little ways to go. Just still a lot of states who don't have any legislation in the works or anything like that. But
Mm-hmm.
it seems like when, especially specifically California, starts to pass some legislation and get the ball rolling on things, it seems like other states eventually kind of get behind that too. So I feel like this state in particular is generally a leader in some of these more, I guess, taboo subjects.
Mm-hmm.
But one other question I had, you mentioned that you work with other social workers who are on the different teams that support patients with other diseases and such. And I can imagine you all work pretty collaboratively together on this topic or other
We
topics.
do, yeah, both.
Okay, good.
We have a pretty tight social work team at Moores that, and team is sort of used loosely because we're on our disease teams, but as a
Sure.
discipline, as a profession, many of us actually have known each other for years, have worked together in other places, and then ended up working together at UCSD. And so we do a lot of consultation with one another in general. And then those of us that work in Aid in Dying meet with our medical director of the Aid in Dying program monthly, and talk about how things are going, and consultation, any questions or concerns,
Sure. Sure.
and to make sure that
And
we're
is that as a whole unit or just individually, or like kind of as you
as a
said,
group.
as a group?
As a
Okay,
group.
cool. And then I imagine there is a lot of data collected on patients, whether or not they use the medication.
Yes.
That's all tracked and regulated.
That's all tracked, and then and we present that information every month to the medical ethics team.
Okay. And just from your own personal experience, have you been with patients before who have used this medication? Have you been involved in that process, or is that something that you haven't had the opportunity to do yet? I suppose.
I did have the opportunity, was asked by one of our patients to be there when she took her medication, and that was a huge privilege for me. Having worked in hospice, I've been with people when they've died, and I felt really privileged to be with her and her family, and it was incredibly peaceful. I think as we like the sense of relief that she felt, that she had reached a point where she was done trying to live with the symptoms she'd been experiencing for a long time. Her husband was there, her stepdaughter was there, and it was very, very peaceful.
Good.
Yeah.
It seems like that's the word a lot of people who we've talked with they use is peaceful, and that's reassuring and comforting as a person who might have to use that option.
Yeah. The the prescription contains a very large amount of morphine, and this woman expressed to me, and then and I've heard this from other people, that she actually said, like, "I feel really good."
Yeah.
You know, and
Sure.
she fell asleep fairly quickly,
Sure.
but in those few minutes before she fell asleep,
She was feeling
she's
good.
feeling good,
Good.
which was, thank God.
Yeah, exactly. I mean, with some of the suffering from the disease, her or other people in this situation, it can be, yeah, it can be to the point where you just can't go on. And
Yeah.
having that option, I think, is very, very important.
Yeah.
Is there anything else that you'd like to share, or any other, questions or thoughts or experiences that you'd like to share about the topic of death with dignity?
I'm more wondering, and you can cut this out if you want. I'm more wondering sort of what it's been like for you to
Sure.
talk to people about it.
Yeah, sure.
Is it, when we first talked about you doing this podcast, you said it almost was sort of academic and detached a little bit. And I'm just wondering what it's been like for you to hear what people think and feel about it.
Yeah, that's a good question, and I try to be honest, and that's one of the things I've tried to be, is honest with my disease and this whole experience from the start. Um, the topic is, as we mentioned, pretty heavy. Probably one of the most heavy discussions you can really have with people. And for me, it's been certainly cathartic is a word that I've used. I think it's been healing in a way. In a way, it's been more reassuring for my prognosis, because I am a candidate to use this drug. For me, I think as well a lot about my family, and how I hope this is something that they can benefit from down the line, or well after I'm gone as well, knowing that I'm in a good place with my journey with cancer.
Mm-hmm.
The recordings have been certainly up and down. I mentioned that we did interview my mom as one of our first guests, and that was very, very difficult for me.
Mm-hmm.
Way more difficult than I would have ever really imagined. And I think based on the guests that we have, it's easier. It was easier talking with you as a professional, not, a direct family member,
Sure,
obviously. Yeah. But I think too that it's very important I've had these discussions with my family. We've been together, we've cried together, we've tried to process all of this together. And naturally, when you're with those people that you care about the most, it's generally a lot more difficult. I think there's a lot more emotions that go with it. And as you mentioned, yeah, initially this was more of like I think, an academic project in a way. And as we're moving forward, I don't mind using my own experience to kind of help lead some of some of these conversations and discussions. But I think in the end, hopefully, it's just this is something that will be there for people, family, friends, other people in this situation, and hopefully it will be a positive thing to listen to or give some kind of hope or reassurance or relief. When you mentioned that about your patient earlier, that was something that stuck with me because I remember when we got to the point in my prognosis where we learned that we would not be able to cure the disease. It sounds weird, but there was a massive sense of relief, kind of in a way, knowing what my path was going to be with this disease,
Mm-hmm.
and knowing that there would also be a point where, when I needed to, I guess, stop fighting, I would have an option that would help me kind of get to that next point or that next realm. So, yes, it's an important topic, obviously, to discuss. And I think people like you and myself and husband and my mom and these others who are being involved, it takes people like us taking that risk to remove that stigma and that taboo,
Mm-hmm.
and make this more accepted within the medical community and society as a whole. So, in the end, there will be good that comes from this, and I think that's what I'm most grateful for. I think this is just part of that journey that I'm on, and hopefully it'll be a good thing in the end.
I'm sure it will be. I think it's a huge gift that you're creating, that you're um, making it something that's um, more information that's available, making it more personal. You're putting the face to it, that this is, or voice to it.
Sure.
Um, and so it's really brave of you to share your experience and to work on this.
Thank you. Thank you. And obviously, brave for you to come on and share your own experiences too. And I know that moving forward, good things will develop.
I'm looking forward to see how it plays out.
Me too. Well, unless there's anything else you wanted to add or ask, I think we
I
had
don't think
this is a
so.
great piece and a great addition to add to the Death with Dignity
I
podcast.
hope so.
So again, I'm Andrew Flack, and we were here interviewing Monika Lingle, LCSW with Moores. Thank you so much for your time and coming
It's
up.
my privilege to be here. Thank you.
Awesome. All right, we will talk to you people soon. Take care.